Well, in this case, while performing scleral buckling, after drainage of the subretinal fluid at 6 o'clock, I found that there were massive subretinal hemorrhage involved and macula involved. As we can see that the blood coagulated very quickly and it's adhered to the back surface of the retina tightly. And so then I used the 25 gauge fluid needle to separate the blood cord from the retina first. And then, as you can see, it's adhered very tightly to the, and then I used the forceps to pull out the blood clot by manually. And then removed the blood cord with the retractor cutter. The blood cord was removed from the original retinal tear. Because the blood coagulated very quickly, so it's not possible to use the pneumatic displacement technique, and then carbon liquid injected and endofolliculation performed.
So this was subretinal hemorrhage during drainage?
During drainage, yeah.
Anything, how do you drain?
I just used the 25 gauge needle to insert the sclera to the subretinal space, yeah.
Manish, how do you drain?
Yeah, I also use a 24 gauge needle, bend it, and then nick it to drain. That's my standard way of draining.
Nati, how do you drain? What do you do to prevent bleeding?
I use MVR to create a sclerotomy and punch a little bit.
You use the MVR blade? Any other tricks?
I prefer to do a sclerotomy wherever the site of fluid is there, and then with a tenosutures needle. It's a curved small needle, tenoprolene suture needle can be used so that you have a smaller. It has some inherent curve with it, so that you hold it in the middle of it, so that you have a restricted entry into that.
Do you diathermize the bed of the sclera?
No.
I do, before I choose the needle site, do a diathermy to that.
Wai Ching?
I did it before, but sometimes that afraid of sticky, the healing when the coagulation and the tissue is stick to the diathermy. Did you ever have that?
Not on the sclera. Oh.
On the you diathermy on the choroid?
No, on the sclera. I don't make a sclerotomy and then I think he opens it and then puts the needle. I do it on the bare sclera where I localize where I want to drain. I just make a diathermy kind of mark there and then drain. So it's a minimal diathermy, but just use that. Yeah.
Wai Ching?
So I think most of the bleeding is from hitting the choroidal vessels. So normally you try to avoid the horizontal where the choroidal vessels are more prominent there, and drain nasally in case you bleed, then you will not bleed into the macula.
What if you have a temporal detachment?
There's other tricks people have done, but I have not tried that successfully. People transilluminate the sclera to try to identify the vortex between the choroidal vessel and try to avoid them. And but I found once you have a bleed, try to excavate the blood is more traumatic because they are clotted. And I think the better thing to do is to try to get the pressure up to stop the bleeding. And then I often put a gas bubbles and have the patient positions so that.
So you do not do a vitrectomy, you just do
I wouldn't, because I found that the clot will be stuck, and then you actually has to enlarge the retinotomy, and taking out the clot is more problematic, I found.
I think for the size of blood that he had, I would do the same thing. He did a great job, remove it, because that was too big. If it's a very mild bleed which has started and you've raised the pressure, I keep the back of the forceps there indented till I have a good look inside, and then only reduce the pressure once I am sure that the bleed has stopped. But very rarely it happens that in spite of doing all this, the bleed tries to trickle behind. So then you have to keep the pressure raised for a while, and if it has gone behind, then I would do a vitrectomy on table like him. Yeah.
Kazuaki?
But if it's still in the periphery, I would also leave it like that.
Yeah, and when you gonna do the puncture of the choroid, make sure that you can increase the pressure by use a cotton tip or something. When you punch, and if there is some bleed pressure, and so the
Yeah, the problem is you don't see the bleeding because you do the drainage and then you look afterwards. Kazuaki?
Yes, and sometimes they use a laser to drainage, and it's very effective to cauterize the vessel as well as the drainage.
So you cauterize the bed of the
Yeah.
the choroid before.
That's right.
What power do you use?
I think the 200 millimeter watt.
And then I assume everybody in the room having laser glasses on when you do this.
So you make a
a good
sclerotomy and
point.
then do the laser.
Yes.
Yeah, exactly. Even the place where I was trained, we had a red laser which they used to, after creating a sclerotomy, they would, at the bed of it, they would create a red and then drain it to prevent this particular complication.
So there are many techniques on how to do the drainage, and I think it doesn't really, it probably does matter how you do it, but the risk of bleeding is always there because you're putting your needle through the choroid, and there's obviously a lot of blood going on there. So one of the things I do is so you do the scleral cut down, as pointed out, do a mild diathermy, and we use a handheld diathermy, a low power handheld diathermy, so the whole thing doesn't melt or doesn't stick. And then you use a 30 gauge needle just to poke the choroid. And usually, it's a very small size. I've seen people using MVR blade. Some people actually looking while doing it, which I don't think you really need to see because it doesn't really matter what happens. You don't have much control over it anyway. But once you drain, then the eye gets soft and you can tighten your buccal. And I assume from the discussion here, you decide whether to go after that blood clot or not, depending on the thickness of the blood. If it's a thinner blood, you leave it alone. If it's really thick, you go after it. One of the interesting things that happened to me a while back is sometimes you get bleeding from the vasculature of the torn retina. Once you're doing a vitrectomy, then you get some blood in the back of the eye. Now, interestingly, so you put perfluorine in, that blood shifts peripherally. So you do your laser, you get everything done, you do air fluid exchange, now all that blood is back under the macula. Now you're finished the case, but then now you have bleeding on the back, and then the question becomes what to do. And as was shown by Zhang, it becomes a traumatic procedure to go and try to remove that. The good news is that because that blood is mobile, once you're done, the only thing you need to do is just basically have that patient face down positioned. And that blood again goes peripheral from the macula, and then the patient should be fine. So if the blood is mobile, the face down positioning would do the trick, but needs to be done immediately.
But sometimes I just leave PFCL in for 10 days and then go back and remove. That happens more often in post-traumatic such hemorrhages where at times, as soon as at the end you remove PFCL, the blood starts trickling back. So PFCL post-operatively, a week, 10 days is also possible to do.
Yeah, the good news is if the subretinal blood is mobile, if you do the positioning, the blood gets displaced. I mean, that's how you displace.